Hi, I'm Gilly Bond, a specialist pelvic health physio, and I'm answering your questions about bladder pain syndrome. I'm going to talk about what trigger points are or aren't. So I get loads of questions about trigger points, and part of it is my fault because I did some research about trigger points. But hopefully this should demonstrate what happens when science moves on. So the first thing to say about trigger points is that we don't really know what they are, but we're pretty sure what they aren't. So there has been lots of research into what trigger points are. And most of you, and hopefully everyone, even everyone listening, physio or otherwise, will know that they're kind of the knots in your tissue. So you can feel them in your shoulders, in the back of your neck. Quite commonly, if you get your hand now and push in that section between your thumb and your first finger, you'll find, and if you feel around, oh, there's quite a painful little spot there where you've got some knotted tissue. Now, any muscle in the body can have trigger points. Can have knotted areas, tense areas. That's completely normal, including the pelvic floor. So you may have arrived at this video because your physiotherapist has been trigger pointing your pelvic floor to help get rid of some of those sore areas. And that can really help. That's a fantastic thing to do, really good thing to do, and it can really help with your condition, whatever you're going through, pelvic pain, male pelvic pain, female pain, bladder pain syndrome. We know it's effective in all of these conditions. Can really change symptoms. It's funny, but touching your pelvic floor can really help your bladder, and it can also help your bowel. It can help your erectile dysfunction. Getting the pelvic floor working functionally and normally is really good for everything to do with the pelvic region. It's like anything else, if you're like this and you're tight and everything's a bit sore, then you're going to have a headache. And a headache in the pelvis, as the book says, is demonstrated and experienced as problems with organs. So, any area in the body can have this tension. It's normal. Often, tension in a muscle occurs in a place where force goes from one direction into another direction. So commonly on your shoulder, if you think about it, this big muscle, your trapezius muscle, goes from right in your top of the back of your neck all the way across to your shoulder, and then like a triangle down to the middle of your back into your spine and back up. So it's got a triangular section, and it helps to lift our shoulders up. It helps to do lots of different things. But that force from the muscles goes across, but it has to turn and go up the neck. And that point where it crosses and it goes up, there's going to be some tension. And that's quite normal because we need an area of tension for the forces to pull against. So the physios, if our physio's watching this is a perineum. You've got to think of an area of tension as a bit of a perineum. It's a central section that allows other things to brace against. We need them. This is why they exist. The pain they exhibit when we touch them isn't necessarily to do with the tension. So we used to think of trigger points as hyper-irritable bundles of muscle spindles with a motor end plate attached, which is a nerve end plate, the end of a nerve attached onto them, which was hyper-stimulating that area of muscles. And we used to think that putting our finger on really hard onto that area and pushing hard on it would stop the blood flow and would allow a hypoxic relaxation, was the technique kind of identified. It was also postulated that would cause a neurogenic change in the tissues, so the nerves would fire differently and that would allow the muscles to relax. And we know that's now not right, and there's been a lot of research into this, so I don't say this lightly. At no point am I taking away from the experience that we all have, that when you've got an area of muscle tension, you press on it and it hurts. And if you press somewhere else, or you press on it, it hurts, and it might hurt in that place or it might distribute and hurt somewhere else. That exists, but we don't know what that phenomenon is properly yet. And this is the joy of science. So we've moved on to knowing that it isn't what we think it is, and it's probably something much more beautiful and complex, like usual, than we think it is. And the best understanding that we have from it, there's a lot of work by John Quintner. He's worth following on Twitter. He's a very clever bloke. And hi John, if you ever watch this, big fan. So follow him on Twitter, but also have a look at his papers. There's some fantastic stuff. If you just put Twitter trigger points into and Quintner into any search engine, you'll get lots of information. They have done oodles of studies. They've put little tiny needles in and sucked out the tissue fluid to see if it's hyper-irritable bundles of muscle fibres. They've done scans, they've done twitch response stuff, they've done EMG studies, they've done surface, they've done deeper filament wire. They've done loads of things, and none of the things they've done prove that it's a hyper-irritable bundle of muscle spindles with a motor end plate attached. That's a theory. And the thing is with science is that we have a theory and we try and disprove it, and I hope that we don't disprove it and therefore we prove it. But if we can disprove it, then we move on to a different theory, which is where I am. So my research, where are we? I'm looking at the time. We're in 2019. My research has been out for about 3 years. Where I was talking about how to trigger point the pelvic floor and relieve some of that pain and bladder pain syndrome in women. Now, that phenomenon still exists, but certainly how we think about it should be completely different. And the best way of thinking about it that I found so far is Helena Frawley's work in 2014-15. She's written a book chapter, which I'll try and find the reference for and put underneath this video. And she talks about tension myalgia. At the moment, that's the best word that I have for explaining the phenomenon of what's going on. So we have an area of tension in a muscle, and it causes muscle pain, my muscle, algia, pain. And so I've stopped using the word trigger point because it's a nocebo. It's language that makes things worse. I get on average 24 emails a day, I have averaged them, from patients all over the world saying, tell me where to find my trigger points so that my physio can get rid of it. Tell me where to find my trigger points so I can use a wand to get rid of them because that will help my pain. Tell me where to find my trigger points. Tell me where to tell my surgeon to cut out my trigger points. And that's awful because we've given patients monkeys to carry. And when you give somebody something to carry, absolutely, if you say this is the reason that you're in pain because of your trigger point, they're going to say, well, let's get rid of it. And then you magically get rid of it and they feel better, and then it comes back. So they have to treat it and treat it and treat it and treat it and treat it. Instead of looking at actually probably what's much more likely to be going on, which is due to our perception of threat, pain. Pain is a perception of threat within the body, that the brain decides how much threat there is at any one time, and we think it's much more to do with that. So you can have loads of areas of tension myalgia within your body, or tension within your body, that don't hurt. Why then does treating them in the pelvic floor make the pain go away? That's the interesting question. And the answer at the moment we have is it's much more to do with desensitizing the nervous system and achieving normal muscle movement. So we know in pelvic pain states, bladder pain, IBS, rectal pain, proctalgia fugax, vulvodynia vaginismus dyspareunia. Can you think of any more? We have to some degree, in the more chronic states we definitely have, but we have to some degree in many of those, a pelvic floor that has a autonomic neuropathy. I know. Isn't that interesting? And that means that the blood flow is not normal in that pelvic floor. And we also know that the muscles are, the nerves supporting that area that run through the pelvic floor aren't firing as they should. They're heightened, but they're also boggy, because if you've got a pelvic floor that's tight and tense in different areas, we've got poor blood flow through it. We've got inflammatory infiltrates sitting there. We've got that they can be causing issues with the nerves. We get the nervi nervorum with really poor blood flow, ischemic pain. We have lots of issues with the porosity of the blood flow from the words are failing me right at the moment. You know what I mean? We've got an autonomic neuropathy. So that means that pelvic floor is not in a functional state, so it's not able to move through its full range of motion, but also that kind of state of being is going to be wound up by the brain and also understood as a potential threat in the brain. There's something really wrong here. Now, we know that isn't true because it's a structural, functional, autonomic issue that can be reversed. So we reverse it, and that's what we do when we're doing myofascial release with patients, when we're doing pelvic floor release, whatever you want to call it. I call it myofascial release. We'll talk about that in another video. Go and watch the myofascial release video. I'll do it next. So when you're relaxing that pelvic floor, you're not relaxing it. you're getting improved blood flow, you're getting it neurologically less active, you're giving it assurance that it's okay for it to be in a more relaxed state and it doesn't need to be protecting. And you don't do that necessarily with your finger. 80% of that you do with the relationship you've built with the patient before you get to the point of putting the finger in. Hopefully you have talked to them a little bit before you do that. And you do that by being sub-threat. And that's really key. The minute that we start pushing hard on trigger points, yes, you might get a localized change in muscle tissue because we know we get a counter irritative response. So if you stamp on one foot after you've hurt your knee, your foot hurts more. Yeah, so putting lots of pressure into a trigger point, area of tension and pain in a muscle, you will change that pain response because of descending inhibition. Doesn't mean it's not going to hurt less, but what you do at the same time if you hurt that muscle is wind it up again, and you give it another reason for the brain to think that in that place there is threat. So if that area becomes tense again, of course it's going to say, oh, I'm tense, oh, bears, I'm under threat. And then it's going to be painful if someone touches it again, which is why trigger points come back and why I need them I need them getting rid of all the time. Now I'm in the gym, I squat heavy. I have a massage every now and then because my shoulders get tight, and sometimes I get a headache if I don't stretch well enough. That's normal. You'd expect that because I'm in the gym and I'm squatting heavy. But that doesn't mean there's anything wrong, and it's not necessarily causing the pain. It's to do with the tension, tissue tension, blood flow. We all know this. Why don't we apply it to the pelvic floor? So in summary, trigger points don't exist. The phenomenon of having pain and tension in the pelvic floor coexisting does exist, but is definitely not a hyper-irritable bundle of muscle spindles with a motor end plate attached. What we don't know is what it is. And when we do know, I'll tell you, because I'll do another video. And it's very challenging. I'm a manual therapist, I've trigger pointed, I've written blooming evidence using the T word, which is now not allowed on my courses as we talk about. Well, it is allowed. I'm not that kind of person. But I've written evidence talking about the T word. And that's out there and people are talking to me about it all the time because of that. But we move on. It's challenging to move on, but you've got to be challenged and move on, else we're not going to keep going forward toward getting better at getting people better. And we're going to keep doing the same thing. So they don't exist. What does happen we don't understand. It's definitely not trigger points. It's probably something to do with how the brain perceives threat, and pushing on them really hard works temporarily but doesn't work in the long term. So when you're working with trigger points, the best thing, and we'll talk about this more in the myofascial release video, is to work sub-threat. So activating the pelvic floor, relaxing the pelvic floor, applying force, but going with the threat level as perceived by the patient. So there are times I'm clambering on the table and putting all my weight through a area of tension myalgia, but it's always with contact, visually looking at the patient, looking at their autonomic nervous system more than what they're saying. So have I got consent from their autonomic nervous system to be doing what I'm doing? If I don't have consent, I back off. If it's painful, I back off. And actually, I don't sit on the areas that are painful. If a right-hand sided pelvic floor is painful, I'll go to their left-hand side and I'll contract, relax lots of side on that side, and I'll come back on this side. It's the same with shoulders. It's the same with anywhere else. Go away from the bit that hurts, work back towards it, double check it. Funnily enough, the pain has changed. We've got some descending inhibition, and hopefully we've got some neurological muscle relaxation as well. Kind of gone a bit myofascial release there, but we'll talk about it fully in the next video. Okay, so if you are watching this and you're now really grumpy because your physio has been chasing your trigger points for ages, they haven't been doing a bad thing. But just know they should never hurt you. Physio should never hurt. So if it's hurting, ask them to go somewhere that doesn't hurt and work their way back. And also, trigger points are not a cause of what's going on. They're a symptom that the system feels that you're under threat in that area. Relieving the tension in the muscles is great, but you don't necessarily have to do that by hammering them with a wand, with your own fingers, or with your physio doing it for you. You can lie in a happy baby pose and breathe deeply into your pelvic floor. You can go do some yoga, you go for a walk, anything that gets your system feeling much more relaxed, and specifically feeling that downstairs is not being attacked by bears. Okay, I hope that's made a bit more sense, and we shall speak soon. Hi, while I've got you here for a second, if you're a physio or a physical therapist interested in learning more about what I'm talking about, how we holistically manage someone in pelvic pain with a much better idea of how to apply the best of pain science in the clinic, then my Happy Bladder course, which is based on bladder pain but is really much more of a holistic view of how we treat all pain states in the pelvis. I'm working really hard to get that up online for everyone, hopefully early 2020, so the beginning of next year. So check back on the website, keep your eyes peeled on my social media, and if you're interested, the course should be going live early next year. Thanks.